Good morning, good afternoon, good evening, everyone. Thank you for joining us from different parts of the world. My name is Yolande Andrews, and I'm very happy and proud to welcome you to NACOSA's series of webinars hosted under the banner of the Amaqhawekazi Harm Reduction project. NACOSA is a networking organization working to build stronger, more equal, healthy, and safe communities free from HIV/AIDS, TB, and gender-based violence. We do this by strengthening community systems, mobilizing and managing resources, facilitating networking and collaborations, providing and enabling access to services, and advocate learning and sharing collectively. NACOSA, through its work with several partners, including Out Wellbeing, has contributed to the publishing of the South African Harm Reduction Guidelines for chemsex in the Southern African Journal of HIV Medicine in 2025. So what is sexualized drug use? It refers to an intentional use of specific psychoactive substances before or during sexual activity to enhance, prolong, and intensify the sexual experience. It's most commonly documented among gay, bisexual, or other men who have sex with men, but it also is very common amongst our heterosexual populations and young people. So harm reduction recognizes that some people will engage in sexualized drug use and seek to minimize health, social, and legal harms. So without harm reduction, the reality is that HIV incidence will increase, overdose deaths will rise, and survivors of sexual assault will not report. So our mental health crisis will worsen and more groups will be marginalized if harm reduction efforts for chemsex or sexualized drug use is not recognized. So today we have various speakers, experts from South Africa as well as from Kenya, who are going to highlight key areas found within their chemsex and sexualized drug use research and programming. Before we start, just some house rules that you are welcome to indicate any questions that you may have from the presentations you hear today in the chat function, and we will respond during the Q&A session or even during the presentations on the chat function. In addition, we have sign language interpreters as well as French interpreters. So please go into your interpretation channel and select the channel that you would prefer. And if you are English speaking and would prefer that channel, please select English in the interpretation channel. So let's start off with our first presentation. And this presentation is specifically from our partner in Kenya. So we have Darlene Okalo. Darlene Okalo will be talking about sexualized drug use programming in Kenya, and specifically around young people. Darlene Okalo is a psychologist specializing in substance use disorders, holding training in both economics and psychology from Agra in India. She is working with the Muslim Education and Welfare Association in Mombasa, Kenya. Her current role involves overseeing a dynamic and expanding docket that concentrates on strengthening and scaling mental health services across community health and harm reduction programs, specifically for people who use and inject drugs. Darlene, you are absolutely welcome, and thank you so much for sharing your programmatic experience as you have found it in Kenya. Over to you, Darlene.
Thank you, Yola. Thank you, everyone. It's good to be here. Allow me to present now what I have prepared. Okay, I hope it is visible to everyone. All right. Now, a bit of introduction. As Yolan has said, I work with MEWA, that stands for Muslim Education and Welfare Association. And as I talk about sexualized drug use. In a bit of what MEWA does, as Yolan has said, it stands for the Muslim Education and Welfare Association. And this is an ungovernmental organization. And our work is just to advance health and justice and human rights for the people who use drugs in the coastal regions of Kenya. In these regions, I have a map there. These regions include Mombasa, that is where I am based. We have Kilifi and we have Lamu. And now in 2023, the organization that I work with, we partnered with the Elton John's AIDS Foundation and came up with a program. We implemented a program which targeted young people who use stimulants in Kenya in sexualized context. And the aim of this was just to reduce health risks, strengthen access to support services. And a hotspot assessment data, this included 470 young people, just a bit of background. And we had 334 in Mombasa and 136 in Lamu. And they were all in the age group of the youth, that stands for 15 to 35 years. The education backgrounds, they varied. We had a few, about 30 of them for secondary and 221 in secondary. Primary education level, we had 188, yet we had just 2 in junior, and we had those that were no formal education, that was 29. With employment status, that ranged as well. We had 49% totally unemployed, 35.3% they're self-employed, and we had 7.4% just doing part-time. This means that they're sometimes working and sometimes not working. This is an on and off arrangement. We had 1.5% in full-time. By full-time, this includes employed and also self-employed. And we had 3.8% students, and we had those who are neither here nor there. That was 2.3%. And a point to note is that 63% of the unemployed were women. A majority of the unemployed population were women. And when we're talking about sexualized drug use, we realize that the drug that they use in sexual activities is cat. In Kenya, we refer to it as mogoka or miraa, but you can call it cat. A little bit of what it contains. In our research, we found that cat contains about 40 components, and there are 3 that I can maybe highlight because they cause psychoactive reaction to the brain. So 3 of the components of this are caffeine. There is a table there. There is a figure you can see on your screen: caffeine, cathinone, and norepinephrine. And when caffeine is ingested, maybe something we need to know is that caffeine is unstable, and it degenerates very fast within 48 to 72 hours, and that is why it has to be consumed raw. It has to be consumed when it's very fresh, and when it degenerates, that is when it becomes caffeine, and when it is consumed, what happens is that it gets into your body and it enhances, it raises it increases the dopamine levels and also inhibits it inhibits the reuptake of serotonin. Now, what happens when serotonin is inhibited? Let me talk a little bit about norepinephrine. When norepinephrine is increased in the body, norepinephrine was historically a medication that was used for congestion, nasal congestion and flu, but in some countries it was banned or prohibited because of the side effects, and one of the side effects was stroke. So in some countries it is prohibited, and this is one of the components that is found in cat. Now, talking about the levels of dopamine increasing, we need to understand what dopamine does to us when it is increased or when it is reduced. On your right side, there is a figure there. You can look at that picture, and that just shows us the pathways of dopamine in the brain. The yellow shows us the dopamine, and the red shows us about serotonin. What are the functions of dopamine? It's about rewarding. It deals with rewarding and motivation. What this means is that whenever someone engages in an activity and you realize that this activity is rewarding, there's the tendency to repeat and repeat. Now, this is done by dopamine. So when it is high, that means that this can be abnormal. And this, we can see this in mentally unstable people. Is also a pleasure hormone. It's motor function. It also goes with movement, increases compulsion, and perseveration. What this means is that someone is not able to control the thought, a thought, an action, something that has happened earlier, and you keep repeating the words, the thoughts to yourself, and you're not able to stop. So we also see this in people who are mentally unstable. That means that is when dopamine goes up. And serotonin pathways, what is the function of serotonin? It deals with our moods, memory processing, also sleep and cognition. Now, sexualized drug use and risks. Focusing a little bit on women, there is a diagram there for the female reproductive system. But I want us to look at our research finding. We found that the frequency of stimulant use for sexual enhancement, this was just for the general population that we dealt with, 14% used cats once every day for sexual enhancement, and 12% used to do daily, twice daily, that 24% twice weekly, 30% 0.4 used once per week, more than once per week, and 14.3 used whenever there was a partner available. Now, this is quite alarming that there is a dependence on cat to boost sexuality. And why were they doing this? There were some perceived benefits, and we realized that these benefits came from maybe social media or just peer influence or just their belief. What were the perceived benefits? One said that it increased energy and stamina during sex. Another one, libido and arousal, improved focus and concentration. Others believed that it caused delayed ejaculation and improved control during sex. It increased confidence and reduced anxiety. Someone said that they could have sex with someone who was maybe more mature, because the people that are unreachable to them, they're able to approach them and have sex with them. And also heightened physical sensitivity, euphoria, and enhanced pleasure. Remember, these are perceived benefits that they reported. This is what they believed that were benefiting them from the use of cats. Let's look at risks. And the risk I'm talking about now is for women, in women. Causes sexual dysfunction and decreased libido. Now, this is contrary to their beliefs. Also, reduced food intake, yes. Decreased utero and placental blood flow. This is when someone is expectant. Impaired fetal development and low birth weight. The general risks, this includes for men. On your left, there is a picture of cat. In case you've never seen, that is how it looks. That is how they look like. They're just leaves. Low doses increase testosterone and high doses reduce testosterone. That's in men. Reduced LH. LH, that stands for luteinizing hormone. Now, this hormone is for reproduction in both women and men. And also elevated cortisol levels. These are stress hormones. 28% reduction in semen volume. That means it can hinder the reproduction among men. Reduction in sperm count and motility. Reduced libido and erectile dysfunction. Spermatorrhea. 50% abnormal sperm production. Spermatorrhea, I also engaged one client who said that they had been, how do I say it? Let's say removing sperms without having sex. So they were having spermatorrhea, and they were having that they were from the word, for example, diarrhea, when you're just releasing sperms, what that means is that the sperms are overproduced and they come out some abnormal. And so because they are overproduced, they have to be let out. And finally, lastly, urinary retention, physical and systemic effects. Insomnia, that one we are aware because it's an amphetamine. We said catenon is an amphetamine. It hinders sleep, appetite loss, and loss of weight, dehydration, among those that we interviewed. Also, jaw clenching, because this is a herb that is chewed for a long time, headaches and muscle pain just from the chewing, tremors and irregular heartbeat, shortness of breath, oral and gastrointestinal issues. This is constipation and also ulcers. Now, for oral, the people who chew this, you find that they have problem with their teeth. Most of the time, their teeth are brown or green. The mouth is always green from the chewing for a long time, and also the liver, long-term liver damage because of hepatotoxicity, mental and health behavioral risks, substance-induced psychosis, and we found so many of them were going through this with hallucinations and a lot of hallucinations, aggression and violent behavior, mood swings, anxiety and depression, agitation, mania and panic, and also paranoia, just believing that people are after them or nobody loves them, nobody cares. We found that to be so prevalent among the users. Why was it necessary for us to look into this sexualized drug use among young people now? We realized that stimulant use, specifically cats, had rapidly increased among the youth in coastal Kenya. Why was it increasing? It is because it is legal, it could be sold to anyone at any time, everywhere and anywhere. So the use was increasing. Drug use had also become closely intertwined with sexual activity, and this increased vulnerability to HIV and STI transmission, and also risky sexual behavior, sexual and gender-based violence. Why were they getting to use cats in their sexual activity? Because there became a general belief that whatever was being used earlier, the blue pill or Viagra, if I may call it, could be harmful, because there have been cases where people are found dead during sex or in such activities. So there's the general belief that this one is safer because they think it is natural. So we talked about the perceived benefits. Now this is just in their perception. Also, why did we have to look into this? Existing harm reduction services are largely focusing on those who are using opioids and depressants, and yet they're leaving the stimulant users without support and without access to services. Also, situational assessment, we also identified 68 stimulant use hotspots within Mombasa and Lamu. So this revealed major gaps. So youth reported stigma, isolation, and discrimination which discouraged seeking care. Now, because we've been focusing on the depressants and the opioids, and yet we leave out the stimulant users. So these youth, they 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 say that they get to be stigmatized. There was also a rising burden of untreated mental health disorders among stimulant users, yes, with a lot of them having psychosis, substance induced, which came from the use of cat. We already talked about depression and that imbalance of dopamine and serotonin in the brain. So there's a lot of that. There's a lot of untreated mental health disorders. Young women also face compounded stigma in sexualized drug settings. This is because the women, I think the general perception of society towards women, whereby a woman who's engaging in taking cat, is treated differently from the others. So they faced a lot of stigma, and this is why we needed to look into this. Our needs assessment and evaluation. Now, in our assessment, I already said that we found 68 hotspots mapped in Mombasa and Lamu, and high stigma, just as the client said. They also had limited access to healthcare and prevention and counseling. Stimulant use, as I said earlier, it is also linked to risky sexual behavior and economic vulnerability. As I said also, women faced a lot of stigma more than the men population. What were our outcomes? Um, in health and harm reduction, we had increased HIV access to services in HIV and awareness, whereby we had 1,159 clients that were tested, and 120 of them were put on PrEP. services. And we distributed condoms, 12,726 condoms, to also help them to curb HIV, the spread of HIV. We also screened for hepatitis, and we had vaccination for all the clients. So we had 28 positive cases of hepatitis C, and 2 of these cases were female. And we had 2 male who tested positive for hepatitis B. We also had CBT, that's cognitive behavioral therapies, and so psychosocial support. We also provided that. And in general, we had improved mental health and reduction in stress and distorted beliefs. And as we were doing this, we also test for depression for every client that we interact with. We screen for depression and anxiety, and from there we are able to arrest in case there is a in cases of severe depression. We are able to take care of these clients. So we had 267 clients who went through 12 sessions of um, of study whereby we trained them and they completed these sessions. At the end of, we had a pre-test and we had a post-test. And at the end of it, when we did the post-test, we found that there was a change, that there was low, reduced depression. Their perceptions had changed. Their beliefs towards CAT had also changed. Policy in economic empowerment, a lot of these people, we put them through vocational training, with many of them going to driving schools, beauty and cosmetics trainings, and also entrepreneurship support. They went through entrepreneurship training, and they were also given seed capital to start up businesses. And for some of them, we also linked them to jobs and opportunities. We also had policy influence. So we influenced policy and media narratives. We also positioned MEWA as a key reference point. Sustainability, we also had community ownership and policy advocacy and institutional integration. We also went to prison. I had the opportunity to visit the main female prison in Mombasa and took the female inmates through the 12 sessions of CBT. And of course, I also had a team that also went to the male maximum prison in Mombasa, and we had we took them through 12 sessions of CBT, whereby at the end of it, we taught them about emotional regulation, anger management, problem solving. We had cognitive distortions, and we taught them about goal setting, social skills, among others. We had 240 men and 150 female, and they all completed this. And we are awarding certificates. What is the role of harm reduction in addressing GBV and HIV stroke hepatitis? We have had integrated stimulant use into harm reduction services. So we also developed an e-learning platform where we specifically, which is specifically for harm reduction and stimulant use. I've put a link there. I don't know whether it's active in case you want to check it out. And we also have mainstream mental health. We have mainstream mental health services through adoption and implementation of CBT across the GBV, HIV, and hepatitis care, whereby we're just creating awareness and helping these people to be mentally stable and also to change their perception. We also had increase in PrEP uptake, whereby we already have 120 clients taking, and 68 of our HIV clients, they are well, they're being taken care of. And as they take their ARTs, we also had reduced number of GBV cases because we also do family therapies for them. We also do documentation and also following up. Institutional stimulant use treatment across 6 sub-county facilities in Mombasa County alone. So we have also made sure that we get into the county, and we have had whereby now our clients, the stimulant users, can go and they get services. The county has also given antipsychotic drugs, psychotic drugs for those that are already experiencing psychosis. So as I said earlier, we also developed an e-learning platform whereby CBT is available for the general population. The legal framework. After we did all that, now Mombasa County came on board, and they realized that there is a problem with this herb cats, whereby it was legal and it is sold to everyone, and now it's being used in sexual activities. And apart from that, of course, there are many people who are in the mental hospitals because of usage of cats. So now the Mombasa County Governor um, declared an executive order to ban the sale and the use of cat in Mombasa County. But now what happened is that people went to court in the counties where it is produced. It is produced in the county of Meru and Embu. So people went to court and they contested this. So the court upheld. Reason was that cat in Kenya is classified as a legal commercial plant, and this is in the Crops Act of 2013. And so there was no way that the county could just ban it. So what happened is that now the Mombasa County government had to go and just regulate, because we can regulate, but you cannot totally ban it. So there are regulation measures that were put in place. For example, regulating sale, not selling to the minors, not selling near the 100 meters from learning institution or religious institution, hours of selling also, tax, tax for the trucks that are coming in, bringing the cat. So Mombasa could only just regulate but not ban. So operationalization of Mombasa County Drugs Substance Act, which had been dormant, now it became operational because of what we had done. Also, executive restrictions, as I said earlier, entry, the sales fee was increased for the trucks to minimize the profit and discourage the purchase. Regulation on sale and distribution, as I said, to be restricted, not to be sold near schools. And also a shift toward public health approach. Now, when the users go to hospital, they are able to be received, and they are given the psychotic medication. I think I am done, unless there is a question.
Hi, Darlene. Thank you so much for your presentation, Darlene. We're going to look to the chat as well as to colleagues to give an indication if they have any questions. I have tons of questions. I think your research and your program really shows an attention to an issue that we've seen in South Africa, which is there are no real harm reduction or substitution therapy options for stimulant users as there is with opiate users. I think your research and programming clearly highlights that. So we'll give it over to the attendees now. If there's anyone that perhaps has a question, you are welcome to raise your hand or put it in the chat. I'm not seeing any hands. So, Darlene, if I may, while we wait to see if there's any questions, I think you've done an amazing job to just present this very clearly. But just a question from my side. It's one thing to talk about substance use and addiction, but it's also another stigma associated with sexualized drug use. In your programming, what were some of the cultural, religious aspects that came into consideration when you were looking at harm reduction programming for sexualized drug use, particularly?
Would you kindly repeat? I'm not sure I got it.
So I'm just trying to understand what was the stigma in relation to cultures and religion regarding sexualized drug use that you came across, and how did you work with that?
Thank you for that question, Yolan. Yes, there was, and there is still stigma. This is something we are still working on, and Mombasa is a religious city. We have a large population of Muslims and also a population of Christians, Hindus, and of course, culturally, we are very different. It's also cosmopolitan. And there are many cultures here, and now it goes with every individual and coming from different cultural perspectives. So, what we do is that we've tried to sensitize the community where we work, and the community where we work, and also just the families of these people, because we intend to fight stigma from the family going outside. So that is why we have also done family therapies of the affected people. One of the things is that mental health issues is in is sometimes deemed as coming from witchcraft, and so people don't seek for help, or maybe just a curse, so people don't seek for help. And now, because of that belief, there has been stigma whereby some people who are not mentally okay are hidden and are not let out even to meet others. So we try to just sensitize and let people know that this is not a curse, and this is a disease like any other disease that can be taken care of through medication, psychosocial support. Yeah, that is how we've dealt with it. Thank you.
So there's one particular question from Tara asking, were there any proven health benefits of the sexualized drugs besides the perceived benefits? Were there any proven health benefits of the sexualized drug use?
Yes, to be honest, there's one. The one, many of them said that it gave them the confidence. That was one of them, but it gave them confidence to engage in sex with anyone, and especially for the sex workers, that confidence to just go out. So it gave them that high and the confidence to go out and do that. So that is the only one that I could say was could have been proven. But remember that confidence is also just short-lived.
Mm.
Thank
Thank you, Darlene. So I think, Darlene, maybe one last question, particularly because of our Amaqhawekazi's focus on women who use drugs. I think my question here is, what particular harm reduction tips are there for women who use drugs, considering the sexual reproductive health risk that you mentioned earlier? What are the particular ones for women who use drugs?
uh, a particular harm reduction tips for women who use drugs. All right. Now, we the first thing we do, of course, is sensitize and educate them. But the main tip is just, first of all, to take care of yourself and your unborn baby first. And then, because we also teach them about the babies who are born with withdrawal symptoms. So once we sensitize that, that is for women who are expectant. But now for those who are not expectant, we also just remind them, because of the stigma and the GBV targeting them is actually very high. It is higher than in the men, and also the societal outlook of how a woman should be, the perception of a woman in Africa, let me say, compared to men. So, like, I believe even in their own view, they say that men could get away with some things that women could not. So when we came to this understanding and realization, now you need to just learn, like, how are you taking the drug? How are you using the drug? And how is it benefiting you? So you look at yourself first. And we covered that in our 12 sessions of CBT, whereby we had to see, like, most of what they were going through is their perception, but they could change. Our aim was not really to tell them to stop taking cards. We didn't do that, but we were teaching them, to just teaching them. And then, of course, at the end of it, there were those who stopped, there are those who reduced, there are those who increased. It was still up to them, but we got some very good outcomes. Thank you.
Thank you so much, Darlene. And thank you again for your presentation. Please share the links to those e-learning platforms. I already saw a comment from Chantal saying this is incredibly important and they would love to learn more. We have the next speaker coming, who is Davi Nell. So Davi Nell is the Executive Director for Out Wellbeing, and Davi will be presenting on their work with chemsex in Soweto, high on HIV and low on retention. Davi now is the executive director and one of the founding members of OUT. OUT is the second oldest LGBT NGO in South Africa and started in 1994. Over the years, OUT has many achievements, such as opening the first Men That Have Sex with Men clinic in Gauteng in 1997 and leading a program to secure same-sex marriages in 2006. More recently, OUT managed the biggest MSM, that's men having sex with men, HIV program in South Africa, in the city of Johannesburg, to address the specific challenges that MSM have in relation to engaging in chemsex. OUT launched as well an Elton John AIDS Foundation funded program in Soweto in 2024, and had many successes. Davi himself has a master's degree from the University of Wits. And Davi, we welcome you and your presentation on an area which most people do not necessarily understand, that it is, across demographics. So thank you so much, Davi. Over to you.
Yeah, thank you, Yolan, and for the opportunity to talk about our work, and then, of course, being a partner to the work that we've done, including the guidelines. So I'm going to talk about our chemsex program in Soweto. For those people who don't know South Africa that well, Soweto is quite a large township adjacent to the city of Johannesburg. All right, just a bit of background to OUT to situate the chemsex program. So we've been providing services to men who have sex with men in the city of Johannesburg from 2018 till 2025. We worked on USAID. They started funding the work in 2018, and I think, as people know, USAID then halted all its programs in February 2025. They funded our basic or the core HIV work, which included HIV testing, ART, and PrEP. In about 2022, during the time of COVID, because we were forced to move away from working in hotspots, we couldn't work in public. We started working with much smaller networks of men. And in that process, we came across a series of chemsex houses in Soweto. Now, a chemsex house is a typical matchbox four-roomed house. There's a gay guy that owns the house or that permanently lives there. And then men from the township come and visit that house to have chemsex. And it's really 24/7, and it starts from 10 in the morning. So this is not just 2 or 3 people, it's a large group of people. We, at the end of this program, we worked with 8 of these houses in Soweto. But just to give you an idea, in these houses, in 1 year, we tested more than 1,000 men visiting the chemsex houses. Just to illustrate the risk, of course, there's multiple risks facing these clients. In the last cohort that we tested of about 200 men, 50% tested positive. And the ART retention was very bad, in about 42%. And for that reason, we then applied to Elton John for complementary funding to support our USAID work and to increase the ART retention among these men. If we can move to the next slide. Okay, the program, we worked with the socio-ecological model. So we started on a small level and worked bigger. On the individual level, we worked with treatment plans. So each client got a treatment plan around the following points: the HIV knowledge and adherence, disclosure of HIV status, sexual orientation, drug use, harm reduction, navigating healthcare, housing, income, family relations, romantic relationships and sex, and mental health. So each client, we work with 127 clients, got a plan according to these points. That was then assisted over a 12-month period by both social workers and informal body support to keep to the outlined plan. On the social and sexual network, we had community advisory boards, we had skills workshop, leisure activities, and gatekeeper engagement. This works quite well. We know from our work that if you work with people from lower socioeconomic backgrounds to create social cohesion and a sense of community, is a very positive health intervention. Then on a community level, we did sensitization and clinical competency trainings, and we integrated chemsex with government. We, for example, played the advocacy role with the AIDS Council to include chemsex in the Global Fund programming, etc. And then policy level interventions. We had the first workshop on decriminalization of drugs for personal use, and one or two others. So I'm going to move now to some of the results this is just some of the topics of our skills workshop. The one is we had a makeup and beauty workshop. We also had a workshop on permaculture, and that is our office in Soweto. Maybe similar to the first speaker, the majority of people are unemployed or very, very informally, loosely employed. And economic empowerment is the important point. But what we sort of discovered, or what we believe, is that you must meet the client where they're at. With this profile of client, you can't, for example, do formal employment CVs, etc. So what happened, for example, the beauty workshop, then people in Hillbrow or Soweto then had already existing clients where they could earn a bit of money. Another client baked scones that he sold at a taxi rank. He taught another peer to bake scones, and in that way to increase the income. Can we move to the next slide? Okay, I want to, before I start outlining some of the results, just for me make an important point. We have to remember that not all chemsex clients' experiences are problematic. I personally engage in chemsex. For me, it is not a problem. I don't necessarily see it as any lack or anything that I'm running from and that I'm not dealing with. I value it as quite a positive experience. And sex gets a lot of bad press. And I think it's important that we also highlight the positive aspects of sex. Sex allows for a lot of role play and play, you know, like people that's powerless in society all of a sudden have power in sex. You know, you can really forget about all your problems and just give and receive pleasure. So we shouldn't equate chemsex as necessarily be problematic. But of course, for some people, it is problematic. And I must say, broadly speaking, the clients that we saw in our program had daily drug use. So for me, that becomes a bit of a warning sign. And that there could be some problematic dynamics underlying. And I think some of this reflects problematic issues. But please, let's not see all chemsex as problematic. So maybe on an individual level, so what I mentioned is that we had this 10-point plan. that the social worker co-developed with the client and supported the client, and also body support. We also sent a smaller group of people to psychologists to try and understand dynamics, and also a small group of clients to a psychiatrist to try and further deeper understand what is at play. But some of maybe I'm cherry picking some results from the individual work. What was quite striking is that people had a very low knowledge on HIV and ART retention. We sort of expected that by this stage of the game, people know how HIV works, why it's important to stay on ART, etc. It wasn't true. They really had very low knowledge. And then, of course, being from a low socioeconomic strata, your treatment is interrupted by food insecurity, lack of money, emotional distress. I mean, a place like Johannesburg is also very migratory. So people move in and out of the city. So that also impacts on the adherence. By far, the most used drug was crystal meth. There was also some cocaine and mandrax. And we tested the crystal. The good news is that there was nothing poisonous or Ratax or ARTs in the crystal. The unemployment is very widespread. Only 10% were formally employed. They live in informal and insecure arrangements. By far, I think about close to 80% of the clients lived with family. And those living arrangements are marked by very, very toxic relationships. The clients had very little commitment to change. There was a hopelessness and a belief of that they are beyond help. They just sort of existed. And were looking for a little bit of pleasure from the drugs and the sex. A lot of clients were raised in broken and dysfunctional families, and that have left them with almost a very deep sense of unresolved trauma. Their relations are really marked by aggression. There's very limited affection. There's addiction, neglectful behavior. They don't hygiene and so on. And there's a very, very deep-seated resentment of what has happened to them in life. And that comes through in all their ongoing relationships. And one always sort of paints these sort of clients as victims. And yes, they are victims. But a lot of times they're the main instigator of toxic relationships. Clients assaulting their family, stealing from their family, etc. So I explained this. We had the initial intake and plan, and then the monthly follow-up and the ongoing body support. If we can move to the next slide. The social and sexual networks, we had discussion groups on a monthly basis. You know, we had topics such as polydrug use, safer drug use, mental health conditions, etc. Skills workshop, makeup and beauty, baking, permaculture, painting and yoga. And then also what worked quite nicely is we took people on hikes. You know, people are caught up in such a small world where things are so difficult. And it's nice just to make them understand there's a big world out there and there's also nice things happening in the world. And I think that shifts things. We also then work with the 8 houses. And what was very nice there is the guy that owns the house. When the clients come at 10 in the morning, you would say that you eat something, that you drink something. We're going to be busy for a long time. So they really came on board with that. And then just some other aspects. We did the needs analysis of the program in Joburg and Cape Town. And then and Andrew and Naeem will talk about the Clinician Society guidelines. And I mentioned the workshop on the decrim of drug use. I think I have one more slide. Okay, so the way forward. I would say that our current cohort, the 127 men, share characteristics with general people who inject drugs. Unemployment, insecure housing, toxic housing arrangement, and regular or daily use. In the full implementation phase of our program, April 24 to March 25, we managed to up the ART retention from 42% to 85%. But I think what one needs to know is that a lot of resources went into maintaining that. And the question becomes, are these type of programs, results sustainable if you don't have this level of resources? So, for example, after March 25, we went into another 6 months with less resources. And also at this time, US aid fell away. But the retention fell then from 85% to 65%. So for me, it seems that one could argue that to achieve good results with this type of client, you need money. You need well-funded programs, including things like where you can take medicines to people's houses. Because for nothing else, people are poor. They don't have money and means to come into a clinic. So you need types of programs that have that level of resources. So the question is that, these programs tend to be a year, 2 years, and we do achieve results, but there might be questions on how those results are sustained once we scale back on the resources. And that is my presentation.
Davi, thank you so much for it. And already there's some questions in the chat. I just want to pinpoint 2 critical things I heard from you. Sexualized drug use or chemsex is not bad. It is not something to be frowned upon and judged. It can be a pleasurable and mentally freeing experience. Where harm reduction comes in is where high risks are taken that endangers you psychologically, biomedically. So that is something I really think was critical in what you said. So thank you for that. The other thing that I heard you say now in the end is about sustainability. The reality is harm reduction works. Harm reduction saves lives. Harm reduction through mobile services, outreach services works better than fixed sites. But how do we sustain it? What is government doing? So you already said you experienced the US aid exit and how that impacted your program. Before we go into the chat, do you want to touch base on that a little bit more?
No, I think you're right. Harm reduction services potentially are quite expensive. And what do you do when there are no resources?
What does the community do? How do we start being accountable?
Well, community, government, what do stakeholders do? I mean, the way I read, for example, DOH level of resources, they're barely able to provide a minimum package. I don't know if there will be resources for additional needed services. And then the funding landscape is also diminishing and changing. So, yes, one can prove it. And one also, for me, it appears that you need to sustain quite a high level of complementary services to biomedical services in order to achieve your biomedical results. If you scale down on that level of intervention, it seems that clients relapse.
Yeah. So one question in the chat is, apart from Soweto, are there any other low-income townships that you've come across in terms of chemsex settings? So that's one question. And I think there was another question, but perhaps you can answer in the chat because we are running a bit out of time, is what are the drugs listed has had the most amount of complications? So which areas are we seeing expansion of chemsex in? And which drugs are particularly having the most complications? Thank you very much, Davi.
Yeah, we did a bit of work in Khayelitsha. It differs in Khayelitsha. There's not chemsex houses. How it's organized there are closed WhatsApp groups that people use to meet each other. Both in Khayelitsha and in Soweto, you can't just, for example, rock up at the chemsex house. You need to know who's the owner. You need to make contact, and only then can you gain access. So it's not that everyone can just walk in. The same with the WhatsApp groups in Khayelitsha. You would need to know who to contact, etc. I think that for gay men, in combination and dangers of drugs, there is a danger. Well, first of all, crystal in especially if you come to injecting crystal, how to inject, making sure that the crystal dissolves properly, that it doesn't clot the veins. And then when you start using crystal with poppers and Viagra and so on, you place tremendous pressure on your heart. The possibilities of a heart attack, and especially for someone like me that's getting older, the risk even increases further. So it's also sort of using all of that in combination. And then more in, I would say, middle class chemsex scenes, there's also GHB, which is the drug, the date rape drug. So that is a very dangerous drug in terms of you really need to know what quantities, the time periods. It's also a cumulative drug, so it stays in your system. So it's not that it works out. So every time you take, it adds and adds and adds. And people can easily overdose and faint and pass out, those sort of things.
Thank you so much.
There are drugs that's used to enhance sexual. I mean, the other thing about crystal meth is that people say you then struggle to get an erection, right? So in a gay context, then the gay guys bottom. So they become the passive partner because they can't get an erection. So there are those sort of specifics to it.
Thank you so much, Davi, and thank you for your time. Could you put your website address in the chat so that people can read up on more of your resources around this? Thank you so much, Davi. We'll move on now to Naeem Kasim. Naeem, are you... fantastic. Thank you so much, Naeem. Naeem is a psychologist that is affiliated with Out Wellbeing. Naeem will be presenting on research or focus group that was done around value and preference of chemsex amongst gay, bisexual, and other men who have sex with men in South Africa. Naeem has a PhD, is a research and counseling psychologist, working alongside Out Wellbeing in Pretoria, specializing in supporting the LGBTIQAP+ community through the challenges of chemsex and substance use. His mission is to combine academic research with a compassionate harm reduction approach. Naeem, over to you. Not Rahim, sorry, Naeem. Good to you.
No problem. Thank you so much, Yolan. I'm going to share my presentation. And let me just say that thank you so much for the honor and the privilege of speaking to you and all the participants online today. A lot of what was shared I will cover, so I'll try and go over it and to maybe give some structure to the conversation as well. So today I'm going to speak to you about the values and preference of chemsex amongst gay, bisexual, and men who have sex with men. And to give you some context, I've completed my PhD, my master's, and my PhD in chemsex. So I spent the last 8 years researching chemsex specifically in South Africa. And subsequent to that, we, together with the OUT and a few other psychologists, we completed the values and preference report, which was submitted to the WHO. And now, not so long ago, recently, we completed the guidelines, the harm reduction guidelines for people who engage in chemsex. And this would be a presentation that I'll share with you that will share some information about chemsex among gay, bisexual, and men who have sex with men in South Africa. And then I've adapted it for taking out all the data that we've done, all the research, I've adapted it to specific focus for the youth in South Africa. I'm going to talk to you about the definition of chemsex. What are the common drugs that we use in chemsex? What is polydrug use? Methods of chemsex use, which my colleagues have covered slightly, so I'll just touch on that as well. What are the motivations? And I want to speak to what Davi said earlier about it's not all bad, so we don't pathologize sexualized drug use or chemsex. And then I will talk to you about chemsex encounters, harms associated with chemsex, and then touch on the harm reduction guidelines and dealing with youth who engage in chemsex in South Africa. So, Yolan, I think you gave us a really nice definition of chemsex. Just to reiterate that, chemsex is defined as the intentional use of psychoactive substances to enhance sexual encounters, particularly amongst GB MSM. When we talk about the intentional use of specific psychoactive substance, it is slightly different to sexualized drug use in that chemsex involves the use of commonly two specific drugs, which is crystal methamphetamine, which is commonly known as crystal meth or TIC, and there's a few other names that is used on the street. And then the other drug, which Davi mentioned a few minutes ago, is GHB or GBL. The method of administrating these drugs commonly in crystal meth is used. You can either smoke it, you can use it intranasally, you can do it intravenously. Intravenously is what we call slamming within the community. The effects of this drug is crystal is a stimulant. It elevates mood, it delays ejaculation, and it can last for about 4 to 12 hours, depending on how much and how often you use. Sometimes you can even go on for like 2 days, an entire weekend. The risk associated with using this drug is insomnia, hypertension, dependency. If you increase your risk, increased usage can lead to dependency. And then GHB, GBL, commonly known as G within the community, or liquid ecstasy. GBL is ingested by means of orally, or some people would do what we call a rectal, a booty bump. So they would insert it via the anus. The effects and benefits and half-life of GHB, it's at lower doses, it can be a stimulant, but at lower doses, it's a bit of a depressant. It creates a sense of euphoria, and it can last for up to 7 hours. There is, as Davi mentioned, there is a very high risk of overdose. It depends on how much you use and how heavy you are. So you've got to be careful with how much, the quantity you use to give you that effect. But if you exceed that dose, you could actually end up going into a coma. And there's also reported cases of death for the overdose use of GHB. We spoke a little bit about, now we know that chemsex is the use of two specific drugs, but they are what we call sexualized drug use. And if you use the two in combination, it's what we call polydrug use. So we know that people who engage in chemsex also use other drugs to enhance the euphoria that they're already experiencing. So you'd find that people who engage in chemsex would also combine it with cocaine, ecstasy, poppers, mandrakes. Some of them use marijuana and alcohol. And these effects, for example, sativa would create a bit of a euphoric feeling, will enhance the euphoric feeling. The poppers may help them relax a bit. So the different drugs have a different effect on the individual, and that's used in combination with crystal methamphetamine. Darby spoke about Viagra. Viagra is very commonly used because we have the condition called a limp dick. That is when a person is unable to get an erection, and as such, they would ingest oral Viagra, and that will help them to maintain that erection during their sexual experience or intercourse. I spoke about the methods of ingestion, and I'm not going to go through the slide, but just to say that these are some of the effects of that. So if you, for example, slam, you can suffer with this. The addiction level is much higher. Smoking or snorting it, you have issues like congestion, nosebleed, a hoarse voice, and there's many other symptoms or side effects to using it. And these are the different ways in which we do. So now that we know what chemsex is, and we understand that it is used in combination with other substances, and we call it polydrug use, the motivation for using chemsex, and Davi quite rightly said, we don't pathologize people who engage in chemsex. Nobody does something to destroy or harm themselves. There's always this feeling that I'm doing it because there's an internal psychological motivation for why I engage or why I take crystal meth and GHB, why I engage in having sex. And some of these motivations that comes from the study is that there's a feeling of loneliness and shame. This could be that they have no social network, they feel ashamed of themselves, their sexuality. There's a perceived or real rejection by family. Some people who come out are rejected by their family and friends, so they become isolated, feel lonely. Body dysmorphia is also plays one of the bigger findings that we come across. People are ashamed or feel insecure about their body. They, in the gay culture or in the queer culture, the masculine, more beautiful men attracts more partners, and those who are not, that don't have the physique, they have this insecurity about themselves, so they use drugs and they're engaging to help them have sex and engage in chemsex. A lack of confidence about their sexuality and a desire to connect with others. Some people are shy, and they have all these insecurities that they deal with. And when you use crystal and GHB, or when you engage in chemsex, you feel a level of confidence that we spoke about earlier. That's the kind of confidence that you get from using the drugs. And when you are confident, you would speak more. When you speak more, you build these connections. How do GB MSM people connect with each other? These are some of the more prevalent ways in which people connect with each other. Chemsex encounters. We have Grindr, which is a very popular, the largest social networking app. You can literally go onto Grindr, and within a kilometer away from you, you could encounter somebody who's also there and possibly also engaging in chemsex, and you could hook up with somebody quite easily using these things. There are these little encrypted or cryptic emojis that the people use on Grindr, that is display that they are interested in chemsex or they engage in chemsex encounters. ViiV, it is a web-based site. It is more for the extreme sexual encounters. So it's men who enjoy engaging in acts of BDSM, extreme sexual activities. And there's a specific context where people who engage or visit the social or ViiV, they do it there because they want to meet other chemsex users. So it's almost very unique and very focused for that. And then Darby spoke a little bit about, there's different socioeconomic classes within South Africa. You have men who go to these houses in Soweto, and you find some people there who engage in chemsex. Sometimes it's younger clients who solicit older or straight men, and they also use the ads for Africa to advertise their services. And their services is that they would give you sex in exchange for money, and the crystal is involved in that interaction or that transaction. There are also other physical sources of connection. In Johannesburg, it's the Rec Room, the factory that's also in Johannesburg. Cape Town, we have a place called the Shaft, and these are places where people come together, they engage, and you have chemsex encounters in places like that. And then there are other farms like Volkop and Windpomp and Rustic Farms. and like hotels. Hotels are also spaces that people can come meet and hook up. This slide, I'd like to talk to you now about what are the harms associated with chemsex. So we said earlier it is not to pathologize. Everybody does it because there's a pleasure behind it. There's a psychological motivation behind it. But we also have to pay attention and focus on the harms associated with chemsex. So when you are disinhibited, as soon as you slam or use crystal meth, you get this feeling of disinhibition, which means you become more brave and you probably will do things that you would not do when you were otherwise sober. And a few of those would be barebacking, which is sex without using a condom. So you would not even think about, hey, I need to put in a condom before I have sex. Acquiring HIV and other diseases such as STIs and hepatitis. And that's because I'm not using a condom. My risk of becoming HIV is much higher. Sexual risk behavior, for example, you would have sex with multiple people at the same time. The risk of overdose, if you're taking GHB, you could go into a coma. And in the studies, we found that a lot of people were sexually violated while being GHB induced in a GHB induced coma. And you also have the risk of stimulant use disorder. Those are the forms of addiction that comes by habitually using substances such as crystal and GHB. Physical harms to the self, Dolly spoke about it, neglect to eat or drink because the stimulant is in your body. When you are on crystal, you don't feel hungry, so you have less appetite. You may forget to take your medications. If you are already HIV positive, you may forget to take your ARV, or you may even forget or neglect to take your PrEP before or after having sex. Dental care, we spoke about that. Fatigue and insomnia, feeling of depression, the come down of that, feeling of anxiety, difficult sleeping, or falling asleep. And these are the physical harms that we do to our body when we use drugs and a consequence of chemsex. We'll have Andrew that's going to speak about the harm reduction guidelines, but just want to touch on this. This is the framework that we use. It was the strongest at all framework that we use to create and finalize the harm reduction guidelines for us in South Africa. And I'll touch on the practical clinical guidelines in the next slide, but I just want to talk about dealing with youth who engage in chemsex. I think the guidelines we created was a guideline for doctors and nurses and anybody in the medical field. When dealing with a chemsex patient is very different to dealing with any other patient, in a sense that these are people who are already struggling with high levels of shame, stigma, body dysmorphia. They've been rejected by their family. So when you come across somebody who is a person who uses or engages in chemsex, it's important to create a non-judgmental, safe space for open communication. It also helps with the retention of this person will come back to this, whether it's an NGO or clinic. Refrain from imposing personal beliefs and instead focus on the person-centered harm reduction approach. So it's not about what I think you should do, it's about what is the best thing for you to do given your situation. Active listening, which is important. Use open-ended questions. Recognize that chemsex encounters often stem from psychological and social trauma or influences. And avoid promoting abstinence. So the thing don't do, we should never say that. Instead, promote a utilitarian, pragmatic perspective that says that let's reduce the harm. And in case of stimulant use disorder, provide appropriate counseling or refer a patient to a rehabilitation program. My last or second last slide is we speak about the harm reduction guidelines. What the guidelines provide, it provides an individualized treatment. So it talks about what vaccinations are required for the patient, and you can talk to a patient about that. We speak about intoxication and overdose management, the come down and withdrawal support, provide information about safer substance use. So, for example, don't share a needle, try and use a new needle when you are engaging or using drugs. Provide information about, discuss the risk involved in substance the patient presents with. And then you also, retention is important. I mean, Darby spoke about the art program and how people were not coming back for various reasons. So that's very, very important to talk about the importance of having the patient come back and committing to a treatment plan. Relapse I think it's important to also speak about relapse, and the guidelines talks about that, because if you are in a treatment, there's no guarantee that that treatment or plan is going to work. There is the possibility that you will relapse, and that's okay. It's not to say that you are now a bad person or you're weak. It's to talk about how do I recover from that relapse. Then, of course, just safe sexual practice. The guideline also focuses on safe sex, erectile dysfunction, and dental oral hygiene. And then my last slide is just to talk about some practical harm reduction measures. So when you're dealing with a patient person who uses chemsex, let's talk about how do you practically protect ourselves. So let someone, if you are about to have a chemsex encounter this weekend, tell somebody you trust where you are going. So if a guy invited you to his house, tell someone you trust, I'm going to this person's house, or I'm going to the rec room, or I'm going to a farm. Practice good hygiene. So douching is very important. Take a shower and practice good oral hygiene. So how a lot of people have these kits where they have a toothbrush, they have the douche in their bags, and they use that. Drink plenty of water. So force yourself to drink water. Keep a hot water bottle with you. Drink water in between your sexual sessions or while you're using drugs. And keep your prep and try and take the prep before, so that if you forget to take it, at least you had one dose. And keep belongings in a safe place. People have often said that they've had their cell phone stolen, money stolen, so protect those things. And these are the practical things you can do before you go to some person's house or a place to engage in chemsex. And then again, not to use or share needles. If you are slamming, get your own needles and keep your own needles on you. And I think these are some very practical things that we could do and share with people who engage in chemsex. On that note, I'd like to say thank you for listening to me, and back to you, Yulan.
Thank you so much, Naeem. Really greatly appreciate it. And the frank transparency in terms of the language we also need to be using. So I don't see any particular questions, but I have some points if you don't mind. One is, it really sounds to me like we have added risk with sexualized drug use when there's polysubstance use, using more than one substance at a time, especially when you're engaging in chemsex or sexualized drug use amongst women and young people. So I think we want to touch a bit about that added risk. And then I think that you've particularly mentioned or stressed how critical psychosocial services, counseling, group engagements with young people that are involved in sexualized drug use is important. And we are seeing, as the funding cuts are happening, less and less emphasis on that psychosocial support for, our beneficiaries. So those are two particular areas, Naeem, if you don't mind touching base on.
So thank you for that. It's a good question. The first one, we speak about the polydrug use in chemsex. So I gave you the difference between the two, but there are cases, and you are so right. The risk is increased. I'll give you a case, an example. If you are using GHB is liquid ecstasy, you've got to take a very specific amount in relation to your body mass, and you've got to take it within a 45-minute period. So you cannot use it less than 45 minutes because you'll risk overdose. But the other thing is, when you mix the GHB, you can't mix it with alcohol, because that's immediately you'll go into a substance use coma. So that increases the risk. So polydrug use is GHB and alcohol together do not go. So the harm reduction is that you would inform your patient is to rather mix it with some orange juice or something else, so that you don't risk going into a coma. And then if you're using crystal and you're going to take crack or cocaine, you are now double dosing yourself with stimulants. So there's also a risk of psychosis, hallucination, and there's a lot of other mental health elements that comes with it. And this very similar. So the interactions of these drugs, I'm not a medical doctor, but from the research that we've gathered, the interactions of these drugs can lead to what we call substance use psychosis. And then you find people becoming paranoid. And when they become paranoid, they can act out in aggressive ways against themselves and other people. We have in the the qualitative research that we've conducted, cases where participants shared accounts where they harmed somebody in the room because they felt threatened by them. And that takes, and then you have other people who say that takes away the fun or the pleasure from it. So those are very practical things that we share with our participants or our clients and patients to say, be mindful of these things before you engage in chemsex. And then I think, yeah, it is very sad that funding is being cut because, as Darby mentioned, there is so much of good that we can do by sharing information with our youth, especially. We must understand that if you are from a queer culture, you're gay, bisexual, or you're or any LGBTIQB plus, you're already suffering from different kinds of minority stress. You already have feelings of rejection, insecurity, and that comes with a lot of mental health issues as well, issues of depression and anxiety. What do we then do? We go and use a bit of crystal because it makes us feel happy, even if it's just for 20 minutes or an hour. And we continue to use the crystal because that's the only happiness that we experience in our life. What does that do? It At the beginning, it's all fair and well and makes you happy, but that leads to what we call increased feelings of major depressive disorder, general anxiety disorder, and a whole lot of other mental health issues. And I do think that government, NGOs need to invest more in our youth so that we can recognize that it is all interrelated. A patient who comes to you and says, I'm struggling with depression, we have to see, is he using substances to manage that feeling of depression or anxiety? It is interrelated.
Thank you so much. I mean, Naeem, I do have another question, but we've run out of time, so I'll put it in the chat. But I really am interested to hear a little bit more, and perhaps we can invite you again about how do we provide harm reduction through virtual platforms. You mentioned quite a few earlier about how you can access or engaging, in partners for chemsex through certain virtual platforms. But these platforms should also be an opportunity for us to provide information around harm reduction specifically. So thank you again, Naeem, for your presentation and for the honest engagement. Well, now, so Naeem mentioned that he's not a doctor, but he is a doctor. And Naeem has particularly provided us a context for chemsex. And as we mentioned before, NACOSA, through work with several partners, and I'll mention them now, TB HIV Care, COSUP, we have also a population health science as well from the Bristol Medical School, ANOVA, ALT, LGBT Wellbeing, the World Health Organization, the Department of Health, the South African Network of People Who Use Drugs, as well as SANAC, as well, the South African AIDS Council. They have partnered together and worked through a particular harm reduction guideline for chemsex that was published in 2025 in the Southern African Journal of HIV Medicine. And I think this is greatly applauded of those partners to take up the mission. So we have a video now from one of our lead technical experts in the country around substance use and harm reduction, Dr. Andrew Scheiber. Dr. Andrew Scheiber is a medical doctor by training who works in harm reduction research, programs and policy in South Africa and in the region. His work focuses on the intersections between infectious diseases, determinants of health and rights. Andrew, as I mentioned, is a technical advisor for TB HIV Care and a researcher at the University of Pretoria. And this video from Andrew Scheiber will give you an indication of what particularly the clinical guidelines are talking to in relation to chemsex.
So thank you for inviting me to take part in today's session. And I'm going to spend a bit of time around the chemsex guidelines that were developed. And I think it's important just to start off clarifying what clinical guidelines are. And these really are a set of recommendations that are evidence-based and informed by values and preferences research for clinicians. And the intention is to support people working in clinical roles. So that includes doctors, nurses, but also program managers and other people that support health interventions of how to approach and engage with the concept of chemsex and people who engage in chemsex. And these were developed in light of a current gap of locally appropriate guidance for clinicians. And partly this gap is in existence because of limited understanding of chemsex, and also that there's not a lot of discussion around these issues in the South African or Southern African context. And so it was really to meet this need of a practice that is increasing and is important for clinicians to be aware of, because there are potential high risk related to drug use, but also to its intersections with health issues and also HIV and STIs. So the intention was to develop a useful, practical, concise set of guidelines that would be developed and published through the South African HIV Clinician Society. And this process was done through a collective of individuals from organizations with expertise in providing harm reduction services and also clinical services to mostly men who have sex with men and other gay and bisexual men, but also other key populations who may engage in sexualized drug use. There was support from the World Health Organization to do some formative work, which was led by Naeem, with support also of ART and of other researchers, to engage with people to understand what their experiences were, what their healthcare needs were, and what their preferences were in terms of what would help them reduce risks. This process and the findings then were taken into consideration along with a review of available local research and best practice guidance from other countries, mostly from high-income settings, because that's where most of the chemsex research has taken place, and aligned in relation to a useful framework that just helps people think of what is happening in relation to drugs, what is happening in relation to sexual practices and risk, and what is happening in relation to HIV and STIs. And what are the interventions practically that healthcare providers can do in response to that, and taking it from an approach of an engagement, which is, first contact, what are practical things that can be asked during history, what's appropriate examination, what are appropriate investigations, what practical counseling or treatment can be provided, and also how to refer people who require additional information. So that's all provided in these guidelines. And they also make reference to the harm reduction guidelines, which the Clinician Society has released, which also provides more detailed information around responding to drug use more generally. So we hope that they'll be a useful tool. We encourage people to use them, to share them, and to really improve our understanding of drugs and of the risks associated with chemsex, and really to help people make more informed decisions and reduce the risks and have pleasurable sex lives, but yet do that in the safest way possible. Thank you very much.
So a great appreciation for Dr. Andrew Scheiber, who provided us that video to give a clear indication of the actual need and use of these guidelines. We are now at the end of our webinar, and NACOSA welcomes you to engage in our previous webinars that we've done last year. Specifically, we had ones done around gender-based violence experienced by women who use drugs and queer women. We also had a webinar around disability and access to services. There was also a webinar around harm reduction and opiate substitution therapy, as well as a webinar around harm reduction services or risk reduction services for young people. So you are welcome to reach on our YouTube channel to access those previous webinar recordings, and that link will also be shared in this chat as I'm looking at it right now. The other thing that we like to welcome you to is that NACOSA launched last year with several partners such as Sandpit, also CCID, as well as other colleagues. We launched a podcast, Say It Anyway podcast. And our first series was actually around substance use, pregnancy, and parenting things that people don't talk about. But the reality is that whether you're pregnant or have children, there are harm reduction interventions you could use to minimize risk to yourself and to your children and to have healthy relationships with your loved ones. So we also welcome you to go and look for the podcast that is available. And there is a screen right now that has a QR code to show you how to access that via Apple or Spotify, or you're welcome to go onto our website to access the link to these podcasts. Ending off now, I'd like to express a sincere thank you to our translators from Happy Clouds for the French and sign language interpretation. This website or this webinar would not also be possible without Stract Activate, which is the technical team that managed this so well. We also like to express our appreciation for Darlene, who presented from Kenya, Davi and Naeem from Out Wellbeing, as well as Andrew Scheiber from TB HIV Care. And lastly, just again to say thank you. This would not be possible without the support of the ViiV Healthcare Positive Action Program grant. So thank you so much all for joining, and we will share the link to the recordings as well as the presentations shortly. Keep well and keep safe.